Welcome
Sounds good.
everyone. It's great to see a good turnout tonight. For those that don't know me, I'm Julianne Fritz. I'm the Research and Education Coordinator here at the Banff Sport Medicine Foundation. So tonight, Dr. Getzlaf, who is our current orthopedic fellow, will be giving his annual fellow talk. So he's our 2024-2025 fellow. So he's at the end of his fellowship and will be wrapping up in a month or so here and heading on back to Saskatoon to continue practice there. So welcome everyone. And actually just a little bit of housekeeping before we begin. If you want to ask a question, you're free to ask any time. I'll be monitoring the chat, so you can either pop your questions into there or unmute yourself and then ask your question as well. But I'll be monitoring that, and I can ask Matt those questions. So I'll hand it over to you.
Awesome. Thanks, Julianne. Thanks everybody for joining. The topic tonight is management of the first-time patella dislocation, which I think is a bit more controversial than I initially expected, to be honest, and a pretty interesting topic overall. So I think there's maybe some new information out there that's a little bit more up to date that we're going to talk about tonight. So the topics that we're going to cover include the anatomy and pathophysiology, as well as blending nicely into the imaging and risk for redislocation. And then we'll talk about the non-operative management, as well as an entity called arthrogenic muscular inhibition. And finally, talk briefly about operative management of this problem. So overall, acute patellar dislocation is a common knee injury, and it's more common in children and young adults. And actually, it's the most common reason for an acute hemarthrosis under the age of 16. And between the ages of 9 and 14, patellar dislocation is actually 3 times more common than ACL injury. And it's the most common significant knee injury in kids. We also know that kids are at a higher risk for recurrence with rates ranging between 40 and 76%. So this is probably a little bit of an unrecognized, hopefully getting more recognized problem that's quite prevalent out there in the population. In skeletal mature patients, it's not as common and overall less likely for recurrence. ACL becomes more frequent than patellar dislocation in this population, with the incidence of patellar dislocation decreasing by age. So to understand this injury, it's important to understand the anatomy of the patellofemoral joint, starting with the bony anatomy. And the patella is the largest sesamoid bone in the body, with the articular surface characterized by the medial and lateral facets, separated by a central ridge, with the additional odd facet presenting occasionally located on the proximal medial aspect. And this blends well with the trochlear morphology, which confers the stability of the patellofemoral joint and includes subtle changes in the depth and width across a path of patellofemoral motion. And this groove separates the medial and lateral facets of the trochlea, with the lateral facet being larger and deepening from proximal to distal. The dynamic stability of the patellofemoral joint is provided by the active muscular forces about the patellofemoral joint, primarily the quadriceps muscles, with secondary dynamic restraints provided by the core muscles and hip flexors. But the vastus medialis obliquus is the one that we pay particular attention to because it's the most influential in the final line of extension, countering the lateral translation and guiding patellar tracking to assist in engagement of in the trochlea. In terms of static stabilizers, the medial patellofemoral ligament is a fan-shaped and isometric structure that arises from the supermedial border of the patella near the fibers of the VMO. And the proximal medial restraints can collectively be referred to as medial patellofemoral complex, and this includes the MPFL and the medial quadriceps tendon femoral ligament. And the patellar insertion of the medial patellofemoral complex is also variable, with patellar and quadriceps tendon insertions, patellar only insertion, and quadriceps tendon only insertions. Additionally, there's 2 distal medial structures that have been described, the medial patellotibial ligament and the medial patellomeniscal ligament. Here we can see the individual anatomy of the medial sided ligaments, including the MPFL and the MPTL. And on the right, we can see on the patellar side, the MPFL insertion on the more proximal aspect of the patella and the MPTL insertion in blue more distally. Biomechanical studies have demonstrated that of these, the MPFL is the most important medial sided restraint. An engagement of the patella with the trochlea begins approximately at 20 degrees of flexion, progressing until about 90 degrees of flexion. The patellofemoral contact surface area increases with the degree of flexion, and it's approximately 24% higher when moving upper body moving under body weight conditions compared with unloaded conditions, meaning that the patellofemoral relationship is crucial for patellar stability. The MPFL provides most of the static stabilization against lateral translation, predominantly in full extension and early flexion. At full extension, the MPFL provides 72% of the restraint to lateral translation, decreasing to 50%, decreasing to 50 to 60% as the patella engages with the trochlea. So when it comes to the dislocations, there's kind of two general categories, which broadly are categorized as traumatic and atraumatic. So the traumatic dislocations typically occur with somewhat of a similar mechanism to an ACL, with a non-contact twisting force with the femur internally rotating and the tibia externally rotating on an ipsilateral planted foot. There's also dislocations that occur with direct force to the medial aspect of the knee, forcing the patella laterally. And then there's the atraumatic, which are more of a subluxation / dislocation episode, and they tend to occur more with activities of daily living. With these lateral dislocations, we typically don't see the patella dislocated because they tend to reduce shortly after spontaneously when the knee is extended. Occasionally, these patients will present to the emergency department with their patella dislocated, like seen in the image here, but most of the time it spontaneously reduces. So along similar lines, the warp state classification is a model that recognizes these two distinct subsets of patients with patellofemoral instability. WARPS is an acronym for weak, atraumatic, risky anatomy, pain, and subluxation. And clinically, patients in the WARPS group demonstrate diminished quad strength and neuromuscular control, especially of the vastus medialis, as well as reduced core stability. These patients describe minimal force or atraumatic onset for the patellofemoral instability episodes. And WARPS patients tend to exhibit multiple anatomic issues that contribute to their instability. And these can include valgus limb alignment, rotational abnormalities of the tibia and femur, shallow or short trochlear grooves, flat feet, or multiple ligamentous laxity. And they tend to present with symptoms more of patellofemoral pain rather than frank instability, and with recurrent subluxation rather than frank dislocations. STATE is an acronym for strong, traumatic, anatomy normal, instability, and dislocation. And patients in the STATE group tend to have strong quads muscles, good core stability, and the onset of their instability is specific to a traumatic episode. And they tend to have not to have an anatomic disposition to dislocate their patella. STATE patients complain more frequently about instability of the patella rather than patellofemoral pain, and they're usually able to describe the specific episode of the patella dislocation. When we examine these patients, the utility of the physical exam tends to depend on how acutely we're seeing them. In the very acute stages, you can expect a hemarthrosis. And if possible, if they're presenting a little bit later, we should be looking at a multitude of different things when we examine these patients. So this includes gait, and including their alignments and rotation, as well as their overall lower extremity alignment. We should check their Baton score for generalized ligamentous laxity. And then with the patella itself, we feel for lateral laxity as well as the presence of apprehension. Should be routine to also check their rotational profile, so check their hip rotation as well as their foot progression angle when you're watching them walk. But one of the most important things that we can look at is the J sign. And so the J sign is it's a sign of basically the underlying pathology of the patellofemoral joint, and the presence of a high-grade J is considered to be a marker of the severity of the pathoanatomy, and it can influence the decision of adding bony correction or to stabilizing procedures in these patients. A J sign is foremost a sign that the forces seen by the patella in extension are significant in a lateral direction, and this will make more sense seeing it in the next slide. And in the context of an isolated MPFL reconstruction with soft tissues, the graft can potentially not withstand these lateral forces during activity and tend to stretch over time. The addition of TTO, femoral derotation osteotomy, or trochleoplasty can be necessary in patients with high-grade J signs, depending on the identified pathoanatomy and the rest of the investigations. So here I just have a short video of a high-grade J sign. So you can see the patella moving laterally as the patient comes into terminal extension. Imaging is mandatory for first-time patella dislocators. X-ray series should include an AP lateral and a skyline view. And the skyline, or merchant views is also called, is definitely necessary, as it's the best view to do is test the presence of osteochondral fractures as well as medial margin fractures. And it also gives a sense of the patellar morphology of the patellar shape. Lateral images can be tough to obtain of high quality, but we need lateral x-rays that are taken at 30 degrees of flexion with the femoral condyle superimposed. And these films help us assess the patellar height, specifically looking for patella alta, as well as trochlear dysplasia. Unfortunately, we often get x-rays that are slightly rotated and the femoral condyles are not superimposed. And these essentially have no diagnostic value in terms of observing for the anatomical factors that we're looking for. So patella alta is essentially a high riding patella. So it signifies a patella that's in a position that's too high above the trochlear groove. And it can be a major anatomical risk factor for patellofemoral instability. And a greater degree of flexion is required to stabilize the patella in the groove with these patients. And they can even have difficulties entering the groove if the patella is high enough riding. So the way that we assess for this is the Caton-Deschamps ratio. And this is distance between the distal edge of the patellar articular surface and the anterior superior corner of the tibia divided by the length of the patella articular surface. A value of greater than 1.2 indicates patella alta. There are other methods for measuring this, and there's pros and cons to each measure, to each technique. But generally, this technique is the one that we use, and the advantages are that it's valid across a wide range of knee flexion, and it remains valid after post-surgical changes to the anterior tibial tuberosity, and it can also be used in children. Another method of assessing patellar alta can be performed on MRI, and arguably this metric's more important as it actually shows the engagement of the patella in the trochlea. So it's measured on a mid-sagittal MRI section of the knee through the patella with the thickest articular cartilage and the maximal length of patellar bone. And the patellar trochlear index corresponds to the patellofemoral contact height. So the length of the trochlear articular cartilage in projection of the patellar cartilage divided by the length of the patellar cartilage. So if there's less than 12.5% engagement, it's considered to be patella alta. It's not influenced by osseous variations of the patella, and it considers the different types of trochlear dysplasia, but it is influenced by the amount of flexion, so it is slightly dependent on the amount of flexion that's present at the time of the MRI. The lateral x-rays are also used to classify trochlear dysplasia, and here we can see a normal trochlea on a true lateral radiograph with a sulcus line indicated by the black arrow located posteriorly to the ventral outline of the two femoral condyles, which are the white arrows. And when it comes to trochlear dysplasia, the most commonly used classification is based on the lateral x-ray and 30 degrees of flexion. This is the du jour classification. So type A is the least severe, and it has the presence of what we call a crossing sign, which you can see on the figure A there. But essentially you can see the lines of the two femoral condyles meeting in the anterior aspect of the trochlea. And this indicates a shallow trochlear groove, but a normal shape of the trochlea. Type B is a coexistence of a crossing sign and a supratrochlear spur. And this is trochlea with marked flattening or even a convex morphology on cross-sectional imaging. Type C is a coexistence of a crossing sign as well as what we call the double contour sign, which can be seen in C there in the image. And on transverse cross-sectional images, the lateral facet is convex and the medial facet is hypoplastic. And lastly, type D is a coexistence of crossing sign, supratrochlear spur, as well as a double contour sign. And this is the presence of a cliff pattern with a predominant and convex lateral facet with vertical or squared off hypoplastic medial facet, almost absent on the transverse cross-sectional imaging you can see the figure there. So on x-rays, this is what it looks like. This is a type A. We can see a crossing sign with the white arrow. And here we can see type B. So present is a crossing sign associated with a small supratrochlear spur. So this would be one with a flat trochlea. Type C, we can see the double contour sign. So the black and the white arrows there indicating the double contour sign consistent with type C dysplasia. And lastly, we see the double contour sign, the crossing sign, and the supratrochlears were all in one, indicating type D dysplasia. So we can also look at dysplasia on MRI, with the lateral trochlear inclination being an objective way to quantify the grade of dysplasia. So on the most cranial section showing the trochlear cartilage, a line is drawn tangent to the posterior aspect of the femoral condyle. So it's a line on the bottom there. And then a second line is drawn tangent to the subchondral bone of the lateral trochlear facet. The angle formed between these two lines is the lateral trochlear inclination, and a value of less than 11 indicates the presence of trochlear dysplasia. And this has been found to have high sensitivity and specificity in the literature. And we can even see negative values for this in severe dysplasia. There are other axial imaging findings to consider as well. So in a normal knee, when the quads is contracted, the force vector of the extensor mechanism acts on the patella directed inferiorly. But if there's excessive lateralization of the tibial tuberosity in relation to the trochlear groove, this leads to lateralization of the extensor force vector, which predisposes to patellar dislocation. So the tibial tubercle to trochlear groove distance quantifies the lateralization of the tibial tubercle in relation to the trochlear groove, and it's measured on cross-sectional imaging such as the CT or MRI in patients with their knee extended. So here's a demonstration of how to measure this. So again, it can be done on CT or MRI. You draw a line across the posterior aspect of the femoral condyles, and then perpendicular to that, a line through the trochlear groove, and then you scroll down to the tibial tubercle, finding the point where the patellar tendon inserts on the tibial tubercle, and the distance between the two is the TTTG. A length of, or TTTG over 20 represents a risk factor for recurrent patellar instability. One thing that we've found with this is that the value of the TTTG is dependent on the through knee rotation. So if the tibia is rotated with relation to the femur, the value can be altered. For every degree of through knee rotation, the TTTG can increase by 0.5 millimeter. And CT scans tend to have a higher through knee rotation than the MRI because the CT scan is performed in full extension. So with the screw home mechanism of the knee, essentially there's more rotation in full extension, whereas an MRI is typically performed between 20 and 30 degrees of flexion and tends to have less through knee rotation. So that's something to consider. You can artificially elevate your TTTG, and we have to look at how much rotation is actually occurring between the tibia and the femur. So another option that avoids this problem is the TT to PCL, which is reference off the posterior aspect of the proximal tibia, and it's a distance from the medial aspect of the PCL insertion to the patellar tendon insertion, and a value of greater than 24 is considered abnormal. I find this method to be a little bit challenging because the posterior axis of the tibia is less defined than the posterior aspect of the femoral condyles, and assessing that line can alter your TT-PCL value, but it avoids the problem of the through knee rotation. But of course, these two measurements have been compared in the literature, and TTTG has been found to be a better diagnostic value overall than TT-PCL. And this study actually found that TT-PCL had not the best diagnostic value, whereas TTTG corresponded highly with recurrence in this patient population. So back to, kind of going with the physical exam is the alignment. And we look at two different things when we consider alignment in patellar instability patients. So that's the coronal alignment and the rotational alignment. So valgus alignment of the lower extremity, even by just a few degrees, can lead to lateralization of the patella and also a modified patellar tilt, which increases the risk of redislocation. And so if you find valgus alignment either in their gait or with normal stance, you should get full-length standing films to assess the degree of the valgus deformity. The rotational alignment is a little bit more complicated, but specifically femoral anteversion and tibial external rotation are what we're looking at, so they can increase the risk for redislocation. And in terms of femoral anteversion, what happens is the patient has compensatory internal rotation of the hip to improve the coverage of their femoral head by the acetabulum. And this internal rotation of the femur leads to a lateral center of force shift along the and increased patellar tilt as the trochlea is medialized. So the femur internally rotates, medializing the trochlea, and there's forces on the patella acting laterally. It can also lead to dynamic knee valgus, resulting in further lateralizing the force vector on the patella, which also increases the patellofemoral joint pressures in the lateral aspect and also elevates the risk for lateral instability. The tibia, in terms of the tibia, external rotation is what is considered to be a risk factor as well, and this is because the external foot progression angle, with the foot being out of plane, the line of progression leads to changes in the typical axis in the knee, resulting in abnormal knee forces, and also exacerbates the valgus position. And we consider all these things to think about the risk of redislocation, because that's ultimately what we're trying to assess when we're working up these patients. And we have to consider each of these when we're looking at first-time dislocators. And the literature has recorded varying rates of recurrence depending on the risk factors that are present. And generally speaking, these recurrence rates are higher than I think that most people would expect. So this study the study of 210 patients aged 9 to 18 found that first-time dislocators in this age group had a recurrence rate overall of 38%. But among patients with open growth plates and trochlear dysplasia, so having both of those factors, the recurrence rate was 70%. So only 30% of these patients did not have recurrent dislocation in this study span, which followed them for 3 years. And what they found when they expanded the age group of this database to include older patients too, was that that patella alta was also a significant risk factor. But overall, patients that were older, squeletally immature, had lower risks of redislocation. So you can see there in the bottom with closed physes, they 64.7% did not have a redislocation. Oh, sorry. The data there is, 8.6% did not have a redislocation if they had no patella alta, no trochlear dysplasia, and were younger than the age of 25. So there's been multiple studies that have looked at the same question, and consistently younger age and trochlear dysplasia are found to be risk factors for recurrent instability. And some studies have also reported patella alta and increased TTTG as significant risk factors, although less consistently. But some of these, as you can see in the table there, like TTTG of greater than 20 in the Christensen study had a odds ratio of 10, and similar with the Sanders study. So quite a few studies are finding that these are very significant risk factors. So because we have all these different things to look at, it can get quite complicated. And as such, there's been tools developed to try and assess the odds for recurrent instability, including this one, which is called the Patellar Instability Severity Score. So this one, they look at age, bilateral involvement, trochlear dysplasia, patella alta, TTTG, and patellar tilt. And essentially, if the score is 4 or greater, the risk of recurrence increases 5-fold.
Hi, Matt. We've just had a question for you.
Sure.
Just to confirm or get your take, are all these measures needed to decide on treatment, as most people seen by physio usually have just like an MPFL reconstruction?
Yeah, so that's actually a great question. And it's interesting. There's been some more recent guidelines that have been released on this, and I'll talk about them in a bit. But generally speaking, I would say that in an ideal world, all of these would be assessed on a first-time dislocator. Sorry, is there a follow-up to that, or if not, I'll just keep going here with but feel free to interrupt me again. Just another tool that has been used is or described, is this one by Getzlaf and Parikh, is that essentially they grouped trochlear dysplasia, history of contralateral dislocation, skeletal immaturity, and a Caton de Chambre of greater than 1.45, and basically gave them all equal weight. And depending on the points present or risk factors present, showed the average risk of predicted recurrence and then the kind of treatment recommendation. So with none of them present, they stated that it's 13.8% recurrence, which I'm not exactly sure how they came up with these numbers, as you can see that there's so much variability in the recurrence rates. But what you can see is every risk factor stacks a recurrence risk, and if all four are present, they're essentially for sure going to dislocate again. And kind of going back to that prior question and why this is important is that we need to assess the risk of redislocation because we don't want them to dislocate again. Because every dislocation creates chondral injury, and patients with recurrent instability are more likely to have severe cartilage damage. And we know from experience when we get that patient that's in even their mid-20s, so a young patient, but they've had recurrent instability, 10 dislocations. When we go to do their surgery and we scope their knee, they already often have very significant damage to the patellofemoral joint. So generally speaking, conservative management has been the treatment of choice for first-time dislocators, and especially in those that are scletally mature. So two of the most commonly implemented conservative measures include functional mobilization with bracing or patellar tape, and the use of a brace. And bracing has been commonly implemented for instability and subluxation, despite the evidence not being really there to support it, which we'll talk about a bit as well. But that all to say that we now try to avoid immobilization because it's been associated with increased risk of patellar dislocation. So more of a kind of historical context, but like casting from ankle to thigh, essentially, for 6 weeks was kind of the treatment of choice there for a while. And I mean, it's varied a lot in the historical descriptions, and I'm sure this is still done today in certain places and things, but essentially this was done because they thought that immobilization would permit kind of scarring fibrosis and of the medial structures. And then when they're removed, that they would be healed and there'd be less essentially residual instability because there's no excessive stress placed upon the joint while they're in their cast. But I mean, we know immobilization has troubles, and these are patients that already struggle with activating their quads. And these patients that were immobilized have muscle atrophy, especially their VMO, and overall more stiffness, arthrofibrosis, and lower kind of functional outcomes. So now bracing has become much more common than cast, but the protocol is not standardized, and there's a lot of variation. And when you look in the literature, there's no kind of protocol that is used for first-time patellar dislocations across the board. So there can be immobilization by locking the brace, limiting the extension, and try and allow the MPFL to heal in a shortened position. Braces that have patellar stabilization built in, but there's a lot of variation out there. And I mean, there have been studies that try and look at this and see what's going to be the best kind of bracing option. And this RCT by Hokkanen found, or they attempted to look at restricting the motion from 0 to 30, so not quite full immobilization, with a patellar stabilizing brace built into restricted motion versus just a range of motion as tolerated neoprene sleeve. And they found that the motion restricted group had greater quads atrophy, worse range of motion, and worse functional outcomes at 6 months. And there was no difference in dislocation at 3 years. So even with the less aggressive immobilization, the patients are doing better with letting them move. So kind of despite the lack of evidence, I'd say the overall current approach is to get these patients into a patellar stabilizing brace, but let them move and let them weight bear. Start weight bearing accelerated, range of motion accelerated right away, get them to physio quickly. And the advantage in theory of the patellar stabilizing brace is that it's thought to help keep the patella in a reduced position while still allowing them to move and hopefully reducing the amount of quads deactivation. And when we look at non-operative treatment overall, we can kind of break it down into 3 phases. So there's the acute phase, which comprises the first 4 weeks, the intermediate phase from 4 to 6, and then the late phase, which is 6 weeks and later. So in the acute phase, first thing is just effusion management, cryotherapy, compression, things like this to try and get the effusion down. There are some that will aspirate the hematomas if there's a significant hematoma present, but the goal is essentially to get the swelling down and keep the pain controlled, and then begin working on the range of motion. And there's a lot of emphasis on achieving early, full, active range of motion. And there's been randomized control studies that compares immobilization, early motion, and found that improved 4-week outcomes in pain scores, knee flexion strength, with letting them move. Additionally, no restrictions are placed on patients in terms of weight bearing following the instability event, and this is also supported by a systematic review that found no statistical difference in redislocation between partial and full weight bearing. So we want to get them using their leg. But the acute phase of the rehabilitation is where we can run into this entity called arthrogenic muscle inhibition. And this is something that we're kind of starting to recognize more. It's going to be getting a little bit more attention, but we need to be watching for this. And in this process, healthy muscle becomes reflexively inhibited following injury to the joint, and it can lead to weakness, activation failure of the quads, volume loss, and it can be caused by a variety of things, including tissue damage, pain, effusion. And so the patellar instability event itself can cause this. We can also see it in post-surgical patients as well. And then this process is all propagated by disruption of normal neurosignaling between the joint and the central nervous system. So what we see is prevention of voluntary activation of the quadriceps, specifically the VMO, but it's not due to structural damage to the muscle itself. It's a signaling pathway problem. And there is a classification system for this because it tends to follow a sequential pattern. So first, the VMO is inhibited, but they're still able to fully extend the knee. But as it gets more severe, they lose terminal extension, the hamstrings start firing, and not addressed, essentially they can lose their terminal extension permanently and develop a cyclops lesion and have some problems. So this is important to recognize, as it can mimic a locked knee, slow their rehab, impact their functional outcomes, and like I mentioned, lead to that cyclops formation and extension deficit. So there was a recent scoping review looking at this in the setting of ACL surgery. The evidence for the treatment of this is not very strong overall, but there is a little bit of evidence for cryotherapy, exercise, and muscle stimulation. So these are all tools at our disposal, but early recognition is the most important thing. To my computer microphone, so I have just a short video to play. Julianne, let me know if there's problems with this here.
Injury or ACL surgeons, physiotherapists, and other healthcare professionals regularly managing patients with acute knee injuries. In supine position, the knee extension deficit is confirmed by visualizing the typical quadriceps activation failure with an absence of vastus medialis contraction on the injured side compared to normal contraction on the contralateral healthy side. After knee injury or surgery, patients typically maintain the ability to contract the rectus femoris, but have a more profound inability to contract the vastus medialis. In prone position, examination of the hamstrings reveals normal tone on the healthy side and a strong contracture of the hamstrings on the injured side. The patient is asked to repetitively contract and relax the hamstrings. The practitioner places their hand against the leg to provide resistance against the contraction, but also gently support the foot on its way down to help fully relax the hamstrings. This exercise is repeated until the hamstrings are fully fatigued, resulting in full knee extension recovery, given a resolution of the muscle contracture. The next step is quadriceps muscle activation. The patient is again placed in the supine position. A pillow is positioned under the knee. The patient then performs heel lifts to straighten the knee. The provider can facilitate the movement by holding the great toe. The patient is then asked to perform isometric quadriceps contractions. Palpation of the proximal part of the patella helps the provider check the correct contraction of the quadriceps muscle. Additionally, it gives the patient a proprioceptive and visual feedback of quadriceps activation. Once the patient is reliably able to contract the vastus medialis, the thickness of the pillow under the knee is progressively reduced until it can be removed completely. During each contraction, you should see the proximal migration of the patella. At the conclusion of the exercises, the patient demonstrates a symmetrical contraction of the vastus medialis and a fully recovered active knee extension. Thank you.
And Matt, just a question for you while we're transitioning. There was a question that came in that's asking, have you seen quadriceps tears in first-time dislocation? And if so, does that change your recommendations for physio?
So I haven't seen quad stairs in first-time dislocation. I'm not sure if Dr. Heinz on if she could comment to that, but I didn't come across that in the literature, nor have I seen it. So it's not something that I'm familiar with. Circling back to the AMI there, I think as I've been educated on this, I mean, it was kind of getting a little bit more popular here over the last few months to kind of look for it and everything. I've definitely been seeing it a lot more, and I think it's definitely under-recognized. And the patellar instability population is definitely a population where this can occur. But I've seen this with, you know, non-operative tibial plateau fractures, quads tear patients, post-op ACLs, and that series of exercises that he went through in that video. It's actually amazing how quickly you can get the VMO firing again and get their knee straight. So recognizing it early is the important thing. So once you're out of the acute phase, which is the first 4 weeks, the intermediate phase, kind of shorter span from weeks 4 to 6, involves a continued focus on dynamic knee stabilizer musculature, as well as the goal of this stage should be to address any impairments found on the evaluation and range of motion in the early phase. So, you know, if we're struggling with AMI or difficulty getting the extension, this is really where it needs to kind of be addressed before we start kind of losing the window where it's going to be easier to get it back. But once the range of motion has been restored, it's recommended to start working on closed chain kinetic exercises from 0 to 50 and open chain kinetic exercises from 50 to 90. And this has been shown to demonstrate less patellofemoral joint reaction forces. I'm not sure I personally understand the biomechanics behind that the best, but it was described in this return to play considerations paper listed here. And then once we're in the late phase, the focus becomes on getting the patient back to the level that they desire. So for patients aiming to return to sports, sport-specific training can help prepare them for this return and increase the safety when returning. But really, there's no well-established return to play guidelines published in the literature for these patients. So we know that athletes can be returning to sport with impairments and functional limitations, and this can increase the risk for re-injury if they return to their prior level of competition too early. So generally, the approach is to use similar kind of criteria as the ACL reconstruction population. So there's a lot of parallels between the ACL injuries and the patellar, like the true patellar dislocators, including the mechanism, the proprioceptive deficits, neuromuscular impairments post-operatively or post-injury. And so it's been suggested that the strategies for return to sport testing after ACL reconstruction be used for these patellofemoral patients as well. But overall, non-operative treatment for first-time patella dislocators has historically been considered the standard of care. And reviews of patient-reported outcomes have found that patients tend to improve, but they don't really tend to return to their baseline. And given this and the higher than expected recurrence rates, we have to consider that conservative treatment for these patients is not always the best option. So when do we consider surgery? And certainly in the setting of osteochondral fractures, we consider surgery, as well as those deemed to be high risk. The treatment needs to be tailored to the individual patient depending on their anatomic characteristics and physical demands. So osteochondral fractures are one of those, must-operate circumstances, and these can occur when patellar dislocations cause a fragment of the patella or lateral trochlea to be sheared off at the time of dislocation. So in the picture here, you can see a large osteochondral fragment off the patella, as well as the donor site there, labeled with a bottom arrow. And these are pretty common. They occur between 25 and 40% of the time with first-time patella dislocations, and they can be very difficult to see on X-ray, and therefore they're often missed if an MRI is not performed. The Jupiter cohort here found incidence of 23.3%. When they do occur, they tend to be fixable. So it's really important to identify these so it can be acted on quickly. We know that if it's been in the joint for a long time and they present late, that they are no longer repairable, and we then turn to excising these fragments rather than repairing them. And really, the best case scenario is to repair them, keep the patient's cartilage within their knee rather than relying on cartilage restoration techniques down the line. Feretsky et al. Also reported a 23% incidence of osteochondral fractures in first-time dislocators. And in their study, they found that male sex and skeletal immaturity were risk factors. And not all of these fractures were visible on X-ray in their study as well, which further kind of indicates that MRI is very important. So the current recommendations for osteochondral fracture management is to fix the fracture fragment if possible, as well as perform an MPFL reconstruction. Because if we're operating on these patients, we're addressing the osteochondral fracture. We know that the MPFL was torn at the time of the injury. And the evidence shows that we have reduced recurrence rate if we perform the reconstruction at the same time. So when it comes to patellar stabilization as a whole, there's been kind of debate over the years about whether we do MPFL repair versus reconstruction. So there's been a lot of debate and a lot of different studies on this, and we'll look at a few different characteristics about why we feel that reconstruction is better. But this meta-analysis by Hurley et al. Strongly supports reconstruction, as both patient-reported outcomes and recurrence rates were more favorable in the reconstruction group than the repair group. And then another issue with MPFL repair is considering where to perform the repair, because not all patellar dislocations have the same zone of injury, and this has been found to be quite variable in the literature, and it has to be accurately identified in order for the repair to have any benefit. And interestingly, even in first-time dislocations, there may be multiple zones of injury along the MPFL. I'm not exactly sure how that works, but if you're trying to repair the MPFL insertion back to the patella, if it's injured mid-substance and patellar, a patellar repair is not the most logical thing. So overall, there's a lot of decision making to make with these patients. These first-time dislocators they don't all fit into the same box, and it's not always appropriate to recommend non-surgical treatment, like has kind of historically been what we've done. So for those that non-surgical treatment is appropriate, which is mainly those are skeletally mature and don't have the predisposing risk factors for recurrent instability, we need to make sure that they're being rehabbed appropriately rather than immobilized. We need to get them moving and get them strong. We need to make sure that we identify and fix osteochondral fractures, and this means that we should probably be performing more MRIs than we are on these first-time dislocations. And when those fractures are absent, we still need to assess the overall risk for recurrence in each patient. And in those that are higher risk, we can use tools like the patellar instability severity score, or just looking at all the different factors. And those that are high risk, we should be considering primary stabilization. If we do operate, MPFL reconstruction is considered the standard and should always be performed, but we can consider additional procedures that we can add depending on the anatomic risk factors. We've got a lot of tools in our box these days with patellar instability, tibio-tubercle osteotomies, trochleoplasties, derotation osteotomies, varus-producing osteotomies. These are all procedures that may or may not be added depending on the patient's characteristics. The appropriateness of each of these can kind of be discussed on their own merits. It's a little bit beyond the scope of this talk, but we need to be thinking about these risk factors and addressing them with a goal of one surgery, address all of the factors at play in the patients that have a really high risk of redislocation. I mean, when we think about these patients where their redislocation rate is 80%, it doesn't make any sense to be treating those patients non-operatively. So overall, it seems there's a trend to being more aggressive with our investigations and our treatment. And recently, these guidelines were released by the European Society for Sports and Traumatology, knee surgery and arthroscopy. And there's a few of them that I wanted to highlight because I found that they were a little bit kind of trendy about kind of where things are heading. So this was divided into two parts. So part one was kind of to provide recommendations for treatment of patients with first-time dislocation, focusing on clinical presentation, symptoms, diagnosis, evaluation, and imaging. And then part two looked at recommendations specifically into treatment, including the non-operative treatment, as well as surgery and surgical strategies. There were 32 total questions. And the recommendations were based on literature search conducted between November of 2020 and May of 2022. So yeah, they assigned grades of evidence, which, I mean, all the ones that I'm presenting had varying, between A and C. There were a couple that were kind of expert opinion, but high levels of agreement between the surgeons that were on the group. So the first one that I wanted to look at here, because I think this goes back to something I talked about early on in the talk, is the trauma intensity leading to the dislocation or mechanism of dislocation important for further decision making? And they mentioned that there's an inverse correlation between the intensity of the trauma leading to the first dislocation and the underlying pathoanatomic risk factors, meaning that low trauma intensity usually indicates more severe underlying abnormalities, and therefore the evaluation of the trauma intensity provides important information. And this should be, you get the patient that has a very low energy mechanism for their first dislocation, that should be sending off alarm bells that there's something anatomically abnormal to allow this to happen. What are the relevant clinical signs in the acute phase? Importantly, they mention hemarthrosis. So in patients with hemarthrosis, they need an investigation with an MRI. When the acute phase is resolved, they recommend normal testing with J-sign, visual assessment of their axial and torsional alignment or the coronal plane and rotational abnormalities, as well as apprehension to look at kind of all the different factors. And they also recommend that in addition to the clinical investigation, you should ask about the patient's family history, bilateral involvement of instability, as well as the mechanism, to be more thorough. Alluding back to that first question that was asked about whether we can indicate non-surgical treatment after just clinical examination, we really need to be performing imaging before we are recommending non-surgical treatment. We need to be ruling out osteochondral fractures and bony abnormalities before we're committing that patient to a non-surgical treatment line. Which radiologic parameters should be assessed? So they recommend, again, at the bare minimum, x-rays with a skyline view, laterals in 30 degrees, as well as an MRI investigation for rotational alignment and lateralization of the tibial tubercle, trochlear dysplasia, and the presence of osteochondral fractures. Is a non-operated first-time dislocator at risk for ongoing symptoms? So in addition to recurrent instability, a variety of symptoms, including pain, swelling, giving way, functional and psychological limitations, and reduction in sports participation affect 50% of patients, reducing their quality of life. Cartilage lesions start in the first episode, and the severity of the damage correlates with the degree of persistent instability. And in which cases should surgical treatment be considered in skeletally mature patients? So they recommend if there is the presence of several risk factors, as well as presence of osteochondral lesions. So again, even in the skeletally mature patients, they're not always non-operative. Just a couple more here I wanted to look at. They mentioned that for patients in which cases surgical treatment be considered in skeletally immature patients, in this category with a greater recurrence rate and age itself being a risk factor, surgical treatment should be discussed with the patients for every scletally immature patient. May I also mention that individualized surgical techniques demonstrate good outcomes in patients with open growth plates, and due to the high recurrence rate, age itself should not be a consideration for, like, we should not avoid doing an MPFL reconstruction in young patients because it can be performed safely in young patients. As I was talking about MPFL versus reconstruction versus MPFL repair, they reviewed the literature and agreed that MPFL reconstruction has better evidence than repair. And when it comes to isolated MPFL versus combined bony procedures, they feel that untreated bony risk factors increase the risk of failure. And for this reason, it's only consistent to correct bony abnormalities at the earliest possible chance to avoid recurrence and revision surgery. However, the exact cutoff for these abnormalities is uncertain, meaning which value of TTTG and which grade of trochlear dysplasia. It's not always cut and dry exactly when to be performing these. They also mentioned that osteochondral fractures are the indication for immediate surgery, whereas all others are not immediate. And they agree that you should perform an MPFL reconstruction at the time of fixation of an osteochondral fracture. And again, the literature, they agree that the literature supports dislocation rates of between 25 and 70% after conservative management of first-time patellar dislocation. However, what is the recurrence rate after surgery? It's actually not super well described in the literature. So hopefully that wasn't too dry to go through the ESCA guidelines, but my takeaways from these two papers was that there's persistent problems after first-time patellar dislocation at a higher rate than we previously recognized. And in general, we need to be more aggressive with our imaging and our workup of these patients. Every first-time dislocator should have an MRI, especially if they're scleally immature. And we need to be assessing for all of the risk factors in the presence of osteochondral fractures so that they don't get missed. Last thing I wanted to cover was just to briefly discuss the BioBrace study that we're performing here at Banff Sport Medicine. I think this ties in nicely because this looks at how do we reduce the recurrence rate in first-time dislocators. So this is a pilot study to evaluate the effectiveness of a biologic augment of MPFL ligament to reduce recurrence after a primary lateral patellofemoral dislocation. The inclusion criteria for this study is that these patients are first-time dislocation within 7 days and that they're skeletally mature. And the exclusion criteria is osteochondral fracture requiring fixation. So when we find out about these patients, we have to see them quickly within 7 days, confirm the diagnosis, discuss the study and the surgery with them. They also need MRI and x-rays, and we also perform an ultrasound to confirm the zone of injury. And then within 7 days, the goal is to operate on these patients. So the surgery itself is we use the BioBrace implant with small incisions to essentially augment the native MPFL. And post-operatively, we don't put them in a brace. We try and get them moving right away, immediate weight bearing, and follow them for 2 years. For outcomes, we're looking at the reduction in redislocation at 2 years, as well as apprehension and J-sign, patient-reported outcomes, functional testing, return to sport, kinesiophobia, pain catastrophizing, medication use, patient satisfaction, as well as complications and adverse events. And the theory is that this internal brace done early will hold the patella in an optimal position for healing of the medial tissues, and early range of motion reduces the quadriceps inactivation, and that the augmented healing will reduce redislocation. And we're hoping that this will result in early return to function in your sport and reduce secondary injury. All right, so that's all that I've got. Thanks everybody for listening. Happy to answer any other questions that patients have, or if or people have, or if Dr. Heemstra has anything that she'd like to comment as well.
Yeah.
Go
We
ahead.
definitely have a few questions in the chat for you, Matt.
Sure.
Just
I'm trying
going
to.
back a little,
Mhm.
one question was actually whether or what's your time frame for the high risk patient for primary surgery, and is there a role for rehab and then surgery after the knee has settled down? What's your take on this?
Well, so it's not like an emergency per se. So there's definitely a role for prehab at getting them as strong as they can heading into surgery. And I mean, surgery should be like, it's like basically like an ACL, right? It's a timely surgery. We don't want them waiting, years for it, but if we can get it done within a couple months, that would be appropriate. It's not like the BioBrace patients or the osteochondral fractures where we're trying to get them into the OR right away. There's time for the prehab and getting strong heading in.
Okay, awesome. Another question from a little bit earlier when you were talking about AMI and VMO.
Mhm.
Kind of on the similar veins to potential quadriceps injury. This question was about actually asking if the do you know of any instances of can the VMO actually be injured at the same time as the MPFL more than any other quad muscles?
That's a good question. I'm not sure about actual like VMO tear, but we know that I'm just going to pull up a slide here. Like the MQTFL essentially inserts onto the VMO and is disrupted in the surgery or in the injury. So you can see that they're just proximal to the MPFL. I don't know of the actual VMO itself being injured. I'm not sure, Dr. Heemscher, if you have any comments on that or if you've kind of seen that report in the literature. I certainly haven't noticed it on MRIs that I've seen, nor have I come across it in the literature. It's
Yeah.
more of like yeah, go
I'm
ahead.
sure it's injured, but if you're talking like torn as in needs a repair, I've never seen that. I'm sure it's injured because it's sitting right next to the MPFL and the patella goes way laterally. So, but it hasn't needed like repair like a quads tendon rupture. But I mean, it's a good point. Like Matt showed you how to get that the VMO activating with the AMI fatiguing the hamstrings. If that doesn't work and you can't get them contracting, that would be an indication to ultrasound that quads tendon and make sure it's intact, right?
Right.
Any other questions? Pop them in the chat. Or unmute, of course. Or any comments even as well.
Just seen comments about the MRI wait times, which I agree 100% how frustrating it is. I can't believe how long some of them are. Dr. Heemstra was just talking last week about a patient who got their MRI appointment for 2027. So just seems like it's a big system problem that we're dealing with.
Yeah, in that regard, Matt, if you on X-ray an emerge, you're an emerge doc, have a history of patellar dislocation, and you see a bony fragment, the MR may not be actually necessary. With the radiographic bony issue, we can assess how much cartilage is with that bone or not. I think the priority is getting the patient to the OR as opposed to the priority is finding some way to get an MR. Would you agree with that comment?
Yeah, totally. I definitely agree with that. The idea behind the MRI with, a lot of, like in the setting of the osteochondral fracture is identifying the other risk factors, which I mean, I think we're prioritizing fixing that fragment as in a timely manner so that it will heal. I think that, obviously we want it to heal. And if they have high grade trochlear dysplasia or something like that, maybe if you don't address all of the issues, is it less likely to heal? It's not necessarily something I've read. But what I would say is that worst case scenario is, if you have to work up the patient further and, do second surgery down the line, that might be something to consider. But I agree with, fix the fragment first. If you identify it, you can fix it. You can also get a CT scan to look at a lot of the actual imaging stuff too, which if you identify that fragment, you can get the CT scan a lot faster to see, does this patient have, a really high TTTG or things like that. And I mean, lots of this clinical exam too. I mean, we look at their axial alignment. I think the whole topic of, does a patient with an osteochondral fracture also need a, varus producing osteotomy at the same time at index surgery? I think that's a bigger kind of can of worms anyway. So I definitely agree with what you're saying there.
Yeah, that's a great point, Mark. And Miles, to that point, if you see the osteochondral fracture, if you can see it on X-ray, then that's an intra-articular fracture that needs a phone call to the ortho on call. So what we do see a lot with in emerge, that gets actually identified at the time of emerge visit, but they get sent off to physio to rehab because we don't operate on first-time dislocators. But as soon as you see that osteochondral fracture, that's that's a fracture, not a sport medicine injury that can be sent to physio. That needs to be seen right away. And then a CT is definitely better if it's faster. But MRIs are always better in general.
Laura, in the
Great.
acute situation, when you do have an avulsion fracture, have you ever added more to the reconstruction than an MPFL? Have you ever done a TTO or even considered a trochleoplasty? Is that being done out there? A very aggressive surgery.
Yeah, I would say it's not being done here because we're not seeing those patients soon enough. And you saw those numbers that Matt showed, like 25 to 40% have fractures. They're not all repairable, but a proportion of them are, and we're just really not seeing them. To date, it tends to be the stayed patients that get the osteochondral fractures who have less risk factors. So they're actually less likely to need those things, Mark. So I have not done them yet. I would definitely consider it though, if it was really obvious, but it tends not to be those patients.
Yeah, that one paper said that male sex and skeletal immaturity were risk factors. But I found a couple other papers that showed varying risk factors, but I agree, like most of the studies out there is kind of more the stayed type patients that get them.
Yeah, and the guys tend to be the stayed patients, and the girls tend to be the warpsy ones, yeah.
Matt, thanks very much for the really helpful talk. Just by way of introduction, I'm a sport medicine physician in Calgary at Innovative. Just so I can maybe communicate to the rest of our group a bit, just curious your thoughts on the big picture for a young athlete with a primary patellar dislocation. Do you in general, obviously the urgent MRI we've already discussed, but do you in general think that all of those patients, if they're young, healthy athlete keen to return to sport, should be seeing a sports orthopedic surgeon after their first dislocation, or do you think there's a role for non-operative rehab and only sending a recurrent?
I think if you're comfortable assessing the risk factors and categorizing them as low risk, then it would be fine not to refer. Like, examining their J sign. I do think it's worth assessing the axial imaging, and if there's a lot of risk factors there, they should be sent on even if they are a young athlete. But I think if they're that patellar severity index score, if you can imagine those lower risk patients and be comfortable in confirming yourself that they're low risk and managing them, I think that's fine. They don't need to see us.
Great, thanks very much.
Yeah. Yeah, I would agree with that. Miles, I would love it if the sport docs were comfortable enough with this topic that they could have that conversation. The trouble is OR wait lists, right? And so if you have an athlete, Patrick Mahomes still hasn't had his fix, right? And he won 2 Super Bowls. So there's lots of patients that can continue on and they'll just take the risk of it redislocating. And I see them and I send them away and say, call me when it dislocates again and you want it fixed. But it's a good conversation and they have to have the right conversation. And then if you know they want it fixed, but at the end of season, then it's great for us to see them because of surgical wait lists and just timing it.
Makes sense. Thanks very much.
Thanks for joining.
That was a great talk. Really appreciate it. We'll pass on to the Innovative Sport Med group this topic. I think there's a lot of great learning points that we could share, and maybe we'll get some of your contact information, Matt, when this is done, because we'd love to.
Sounds good.
Expand your knowledge.
All right, sounds good.
Yeah, Matt, this is a really thorough review of this, and you've got to disseminate this information. I think it's important you repeat this talk. Maybe in Saskatchewan.
Yeah.
But no, it's a super good review. You put a lot of work into this and I congratulate you.
Thanks, Mark.
And also just a reminder too, everyone will, all the registrants will get sent the link to the recording as well. So you'll be able to disseminate the tonight's recording through your network as well, which will be greatly appreciated. It will also go up on the Foundation's YouTube channel.
Awesome. Thanks for your help, Julianne. If there's any other questions, I'm happy to answer them. If not, we can wrap things up.
Yeah, it looks like no more questions. But for sure, reach out if you want anyone's contact details. And like I said, we'll share the recording. And thanks, Dr. Getzlaf, and thank you everyone for joining and all the great questions. It's been a great session tonight.
Awesome. Thank you.
Thanks everyone. Have a great night.